Well, everybody joining us, we're coming up on noon. So it looks like a lot of people are coming on. I'm going to go ahead and get started on our introductions though. So we can get started on time. Thank you. I am Shar Byington and I'm helping out with the Dean's office. So I'm happy to do some introductions today as the team discusses, as you can see in front of us, the new approaches to HIV and STI prevention. So as you see on the list of slides, thank you for having that up for me. It makes this easier. We have Kristen Vandegreen and David, I'll come back to you. Ryan, Lindsay, and Namdi, I'm sorry, I'm going to pronounce your last name wrong. Mwateke?
Moiteke.
Got close. Thank you.
Close enough.
Our Masters of Public Health program. And then we're joined by David Hatchie, who is our PharmD. And David, I'm remembering you from being family medicine. I could be totally wrong on that. There we go. So I'm going to let these wonderful people take away the presentation. And thank you so much for joining.
Thanks for the introduction, Chair. Yeah, so this the Idaho Collaborative for Infectious Disease Prevention and this presentation are made possible by funds from the CDC and through the Idaho Department of Health and Welfare. So our objectives are to describe the epidemiological and then workforce trends of HIV and STIs, and to explain current prevention strategies and discuss the challenges, barriers, and future directions for HIV and STI prevention. So the CDC estimated about 68 million STI cases in the year 2018, and then of which a total of 26 million were new infections acquired that year. So in essence, 1 in 5 persons in the United States had an STI on any given day in 2018. And similar to the United States, Idaho also faces challenges with HIV and STIs, with the rates and absolute number of cases of HIV, gonorrhea, syphilis, and chlamydia increasing steadily over the past 2 decades. Here we see that the incidence of HIV hasn't dropped remarkably since 2008, with number of cases dropping from just about 47,000 to about 38,000 in 2022. So not surprisingly, the prevalence is also on the increase, because as we have seen, there's only a minimal decrease in incidence, and added to the fact that HIV treatment has made survival from HIV longer. In Idaho, the pattern is rather erratic, but overall, the incidence hasn't changed much. It's because the number of cases only dropped from 48 in 2008 to 41 in 2002, number of new cases. Again, the prevalence is also on the increase here in Idaho for HIV. HIV has a astronomically higher prevalence among men who sleep with men and transgender women compared to heterosexual men and women. And for both homosexual and heterosexual contacts, there is a much higher incidence among Blacks, followed by Hispanic and Latinx populations. Rural residents have more challenges in terms of barriers to care, and are also more likely to have poor outcomes compared to their urban counterparts. And STIs, there's been a surge in syphilis, leading to a more than 31-year high in the incidents or the cases of neonatal syphilis, congenital syphilis, with up to 3,755 babies born with syphilis in the year 2022. We see the trends in the prevalence of primary and secondary syphilis, with number of cases continue to increase here in the United States. And this is the trend for Idaho. And chlamydia cases in the United States since the year 2000 up to 2022. Here in Idaho, also the trend also is a similar increase For gonorrhea also, in the United States, and continuous increase, and in Idaho. Yeah, so similar to HIV, rural residents have higher rates of negative outcomes and compared to their urban counterparts for STIs. So barriers to healthcare, including workforce shortages, contribute to increasing the disparities in the incidence and prevalence of HIV and STIs among different groups. More than 80 or about 80% of counties in the United States not have an infectious disease physician, and only 4.2% of employees of local and state health departments, public health departments, have a public health degree. And before the COVID-19 pandemic, less than 30% of local public health departments had an epidemiologist. And so we can see it's not difficult to figure out that infectious disease roles are being filled up by people from other fields. And so like here, for example, here in Idaho, some public health departments, districts have resorted to using non-degree holders to fill up disease intervention specialist roles. So recognizing the nationwide shortages in infectious disease and public health professionals is important in designing interventions that are aimed at improving prevention, harm reduction, and care for people living with HIV and STIs. So in June 2022, ISU partnered with the Idaho Department of Health and Welfare to start the Idaho Collaborative for Infectious Disease Prevention, ICIDP, and with two goals: developing and implementing an interdisciplinary curriculum geared towards building the capacity of Idaho's health workforce to respond to infectious diseases, and enhancing interprofessional collaboration partnerships and workforce development. So based on curriculum mapping and inputs from faculty members across various public health program departments and programs on ISU, and inputs from also partners across the state, we were able to develop 10 online modules which are offered free of charge through the Division of Continuing Education and Workforce Training. And since the inception of those modules in November last year, we've had about 120 enrollees, including community health workers and healthcare professionals from different healthcare organizations, the tribal health services, and members of staff of Idaho Department of Health and Welfare, and public health districts. Of course, students of health programs here at ISU. And so then the School of Nursing has also made these 10 modules part of the requirements for their course, Population Health Nursing. And so these are demonstrations of participation and support from the relevant academic and professional communities in the state. And we are also currently building 5 advanced modules that will be used for continuing education by healthcare providers.
Okay, thanks. Yeah, thanks, Namdi. So we're going to shift gears a little bit and talk about tools in the toolbox that that we can use to help prevent new infections of both HIV and STIs. And really, we're going to focus on some of the pharmaceutical interventions. And the main tools that we're going to talk about are HIV pre-exposure prophylaxis, which goes by the term PrEP or HIV PrEP. HIV post-exposure prophylaxis, we're going to talk just very briefly about that in both the occupational sense and the non-occupational exposures. Touch briefly on vaccines and introduce a new concept of preventing chlamydia, gonorrhea, syphilis with the use of doxycycline after sex. So the concept of HIV prevention is obviously not new, but the research that's been done has been extensive, and the data is, to be frank, is quite overwhelming of how effective these products are. And a lot of the challenges come through actually implementing providers being comfortable with using them. But this first concept of the use of medications, as you can see over on the right, is that we use antiretrovirals, medications generally used to treat HIV. We'll use 2 of them, and as they get absorbed into the body, they make their way into the cells. And when there is an HIV exposure, there's enough drug to help prevent the infection from taking place. And this, the use of PrEP is generally used in individuals at high risk, such as men who have sex with men, injection drug use, as well as the heterosexual population with multiple sex partners. Next slide. So there are 3 fundamental types of PrEP that we use here in the US. The first is daily oral medication, and we'll look at that here in a second. And then for those individuals who may not engage in high risk either sexual activities or drug use, we can use on-demand PrEP. And this is also referred to as event-driven PrEP, where when somebody does have an exposure, they can use the medication. And then last, we have now multiple options for long-acting injectable medications that can either be dosed every 2 months and soon every 6 months with extraordinary outcomes. Next slide. So this is an example of a person who, once they meet with their medical provider, deem it's a medication that will help them prevent getting HIV. They just start the medication and they take it every day. And when taken every day, it is nearly 100% effective at reducing new infections. However, we know that much like oral contraceptives and preventing pregnancy, that there are things aren't perfect in the real world. Next slide. This is an example of on-demand PrEP, where if somebody knows that they might have an exposure coming up, that they take 2 tablets anywhere between 2 and 24 hours prior to sex, and they have the sexual encounter, and then 1 tablet 24 hours after sex, and 1 tablet another 48 hours after that pre-sex dose. And then this is an example of the last FDA-approved product. This is an injectable cabotegravir. And the timing of this is dosed time 0, again at 1 month as a sort of a loading dose, and then every 2 months after that. And this injectable has also been shown to be highly effective, greater than 90%, when patients have on-time injections. Next slide. And just as a couple quick points on who should be screening for PrEP. So the healthcare providers should screen all sexually active adults and adolescents with information regarding HIV pre-exposure prophylaxis. It's a concept that now patients are actually driving their providers to prescribe, but it really should also be on the shoulders of the medical providers to be able to initiate through conversations about sexual health and sexual activity if some sort of prevention methods are warranted. After a brief sexual history and the risk determination for contracting HIV, then PrEP can be initiated. It's not a long, extensive, drawn-out process. It is the medications are for adults and adolescents weighing at least 35 kilograms, and individuals having anal or vaginal sex in the last 6 months and any of the following, such as a sexual partner with HIV, bacterial STIs in the last 6 months, history of inconsistent condom use. And then for persons who inject drugs, these medications are also effective at reducing HIV, as we know that there are high rates of transmission in the injection drug use population. So for people who inject drugs who have a partner with HIV or share equipment, or also have high risk sexual activity for acquiring HIV. Next slide. So for those of you out there that may want more information, there's lots of great resources. And the one I direct most of the students that I work with or providers is the National HIV PrEP curriculum. And this goes through, it's a self-directed, self-guided curriculum. It covers the medications, patient selection, dosing, unique situations, everything to sort of get you the up training that you need. And once baseline labs have been done, requires ongoing monitoring about every 3 to 6 months, depending on the medication that the patient's on and how they're taking it. And one thing to take note of is that it does take, in some cases, up to a few weeks to become effective, depending on the type of sex individuals are having. So usually it takes about 7 days to develop high enough levels in the rectal tissue, where in vaginal tissue, it takes about 3 weeks. So patients want to make sure that they're using secondary barrier methods to reduce the rates of transmission. Next slide. And probably the most exciting news to happen out of the HIV PrEP area is this twice yearly lenacapavir medication. That all the studies, there are about 5 studies that have examined this medication. All of them have shown 0 new infections in the group provided lenacapavir, and we don't know the price, we don't know the implementation. It's not FDA approved yet. It most likely has been filed and will be approved sometime next year. And this is a subcutaneous injection given again every 6 months, and I think we'll have some interesting implementation discussions in the next year on this. Next slide. So shifting now to HIV post-exposure prophylaxis, there it comes in, again, we think about this in 2 flavors. First of all, for all of you working in healthcare, we have occupational exposure. And this comes from needle sticks, exposure to blood products, contaminated equipment, et cetera. And the nice thing is that there's really only been 1 confirmed case of health provider acquired HIV from occupational transmission last 25 years. We have great options of both screening and treatment that allows for the prevention of transmission. And really the data suggests that starting 3 drugs within 72 hours of that exposure can reduce transmission risk. The issue is sometimes being evaluated, finding the medication, all those things can prove cumbersome sometimes. And actually go back 1 slide, please. Then on the other side, we have non-occupational exposure. And these are individuals that either have been exposed to HIV through sexual activity or sexual assault, somebody that may have had used unclean injection equipment. So with that, the highest rates of transmission come from blood transfusion, receptive anal intercourse, needle sharing. Those would be the highest risk. Moderate risk would be receptive or insertive vaginal intercourse, insertive anal intercourse, and really low risk that a lot of times we do not use post-exposure prophylaxis is receptive or insertive oral intercourse. And then anything negligible, biting, spitting, sharing sex toys, those things, again, have very, very low risk of, to no risk of transmission. Next slide. Okay. So once somebody does have either an occupational or non-occupational exposure, really an appropriate workup for those in having an occupational exposure, working with your employers, a lot of times going through occupational health, and maybe even starting workman's comp claim. All of those things are important. And getting that baseline HIV test is critical because patients have been identified as having HIV after an occupational exposure, and when HIV was already pre-existing in that person. For women, also getting a pregnancy test is important, and other STI testing in non-occupational exposures. And what this looks like is essentially a 3-drug combination used for 28 to 30 days, 1 pill once a day, very benign, very well tolerated, and just making sure that the persons that had the exposure are following up appropriately for routine HIV testing to make sure there's no seroconversions in going from HIV negative to HIV positive. Next slide. And obviously we have vaccines, and we know that Idaho has a very low vaccine uptake rate in lots of areas, and these are no exception. Besides HPV and Mpox, I did want to comment that other STI preventable diseases include hepatitis A and B. Those can be acquired through sexual activity and are recommended in individuals that are at risk. But outside of that, we have HPV, and we've talked about HPV actually in this forum before, so I'm not going to belabor it. But we do have Gardasil and Gardasil 9 that covers for the 9 HPV serotypes that are more oncogenic. And we do know that the use of these reduces rates of oropharyngeal, cervical, anal cancer. They're just extremely effective, and really should be initiated in younger ages, generally around 11 to 12, can start as early as 9, and but generally before sexual debut. And then anything after 26, that's kind of a cutoff where the data is a little bit limited in its benefit. And then the other one that has received quite a bit of press lately is the Mpox vaccine. And this reduces the likelihood of contracting the monkeypox virus. And this is more of a global concern, but we did see lots of cases in the US over the last couple of years. And we have 2 vaccines, and the Jynneos vaccine and the AKM 2000. And Jynneos is an attenuated, non-replicating vaccine that is used in persons with HIV, and the other one is generally not recommended in the US because it's a replication competent virus. And before we go to the next slide, I just also wanted to make a brief comment that although Mpox is not necessarily, is transmitted other ways sexually, it's transmitted from close skin-to-skin contact. And a lot of times in individuals having sexual activity that may have that exposure to skin that's contaminated and sores, that's where we see a lot of the transmission. Next slide. So this is the vaccine dose for Mpox. You get a first dose, and then roughly 28 days later, you get a second dose. So it's a 2-dose vaccine, and then you're done. Next slide. And we have different ways of giving it. The first is a 0.5 ml sub-Q injection. And the US stockpile was a little bit low, and because of that, there was an intradermal option that was being used. That's a 0.1 ml per dose, and that is still acceptable if there are low access or supply issues and you want to extend your stock. Next slide. So the last thing I want to comment on is STI post-exposure prophylaxis. And this is a new concept that's being referred to as doxyPEP, which is the use of doxycycline for post-exposure prophylaxis for other STIs. And generally, we, again, as Nandi showed, rates of chlamydia, gonorrhea, syphilis are increasing. And we know now from clinical studies that taking doxycycline within 72 hours after unprotected sex has been shown to reduce STIs in men who have sex with men and transgender women. Right now, the current studies done in cisgender women have not shown a significant reduction in STIs, but there may have been some design issues and flaws with those studies, and we're still investigating that. And you can also see, again, the CDC now has guidance on the use of doxyPEP. Next slide. So essentially, there's been some discussion and debate around the use of this. Will we be adding to resistance in the community? Will we be adding to increased rates of other STIs if people feel comfortable using this? So What we do know is that the use of doxycycline in other conditions such as acne has not led to dramatic changes in resistance at a community level. And so really what we're talking about is patients, who are using this can get some gastrointestinal as well as dermatologic adverse effects. But really it's quite benign and the drug's been around forever. So who are the best candidates? Generally anybody asking for the product. They should be provided with it. However, if you're screening, then identifying individuals that have had at least one bacterial STI in the last 12 months, and who may identify as gay, bisexual, or other men who have sex with men or transgender women. Good baseline screening prior to initiating, making sure there's no pre-existing diseases as well as HIV. And it really consists of using 200 milligrams of doxycycline within 72 hours. And then having the patient come in every 3 to 6 months for evaluation and determining whether or not they need additional medications or refills.
Thanks, Dave. I always look forward to Dave's knowledge and updates on the current state of biomedical interventions and the exciting developments that happen and that we're in the middle of. And yet with these developments in biomedical interventions, we know that their effectiveness is only going to go so far if we can't simultaneously address some of those drivers of health, those social determinants of health. And so acknowledging the limits of behavior change approaches, even with great effective medications, if there's not infrastructure to support that individual adherence, to support their adherence, to provide access to the medications, and then if there's just continual reinfection through other things like injection drug use, then our efforts are going to be limited. So that is why we're going to spend some time talking about supportive policies and structural interventions. Also acknowledging that treatments, while treatment is prevention, as Dave aptly showed, oftentimes these interventions are downstream efforts at prevention when there are many things that can be done more upstream. So this is just a refresher, next slide, on the socio-ecological model, which posits that that there's individual level influence or knowledge, attitude, your attitude, your skills that drive your health. But then there's other levels of influence, from your social networks to your organizational environment. That could be a clinical policy or setting, your community values, your norms, social norms, cultural values, and public policy. And then these arrows indicate that oftentimes it's true that when we're trying to change health at an individual level, change knowledge, change attitudes, habits, or increase skills, those often take a lot of one-on-one individual effort that is substantial, and yet in public health we know that there's increasing population impact as you go out in these concentric circles. So when you're able to affect public policy that helps provide access and education to a medication, for example, that is going to require certainly some effort, and I don't want to minimize the effort it takes to get policies passed, but once passed, then less individual effort to because that population impact will be broad, and there will be a lot of everybody will be implementing the same pieces. So that's the idea behind the socio-ecological model. Next slide just shows some examples of how this can apply to one of the prevention biomedical interventions, PrEP. So at the clinical level, for example, Dave mentioned that, you know, everybody should be screening and determining eligibility for PrEP. All adults at a certain age should be screened for that, so that it's not being driven by the patient asking for a prescription, but that it's being assessed across the board. Other clinic policies listed there include, you know, the pre-initiation counseling session, routine follow-up procedures, facilitating access and enrollment in health plans that will help pay for medications, and then documenting and evaluating the uptake and outcomes. Those are things that can be done within a clinic and controlled at a clinic level. Then more broadly, go back. The community policies for PrEP include lots of different strategies and policies at a state or federal level that can impact HIV transmission, things like needle exchange programs, which we have had legal in Idaho, but were recently reversed, so we do not have those anymore as of July 1. Access to opioid substitution therapy like methadone or other prescribed opioids with longer lasting use and less propensity to be abused would be another policy. So these are, I'm not going to list all of those, but you can see there's community policies that would help support PrEP indirectly or directly, but through the community level policies. And so to further illustrate this, we'll do a case study. Next slide. For John, a person living in HIV in a frontier town in Idaho. I'm not going to read everything on these slides, but I also just want to point out before we get into this that this is simplified. It's not to say that it's simplified to show the levels of efforts that can happen at the individual level, at the interpersonal clinical levels and policy levels to help support John in his in how he deals with HIV infection. It's so there's these aren't to say these are the only strategies or even necessarily the best strategies, but so John has been in this rural state with limited healthcare infrastructure in frontier areas. He was diagnosed with HIV 5 years ago. He struggled with adherence to his medication due to isolation, stigma, transportation issues, and local HIV care services. But how was he able to successfully adhere to his antiretroviral therapy? Let's move forward. Some at the individual level, some interventions that helped support his adherence were access to telehealth, which greatly expanded with COVID, and yet the infrastructure around it is still developing and how to bill for that, but it's becoming much more accessible. And in John's case, that can help him receive that medical advice that he needs and be monitored better for adherence to his medication. Adherence counseling, working through barriers, developing strategies, motivational interviewing types of things, and then digital reminders, you know, through texting, for example, can all be interventions that help him at an individual level have those education and skills necessary to improve adherence. Next slide. So in the interpersonal level, again, he's in a frontier setting. If he has decent access to broadband, there could be, for example, an online support group that could be an example of an interpersonal intervention that could help provide that emotional support, talk to others about how they're handling their infection in rural areas, connecting with people like him so that he feels less isolated and more empowered. Also, having support from family, for example, family education and involvement would be another way. Before we go to the next slide, oh, can you go back? Naudi, I'm going to just say that if you think of other interventions that could possibly support John, feel free to put them in the chat, and I will try to look at that as well. But think about clinic level interventions to support HIV medication adherence. What could a clinic do? We're just going to highlight 3 on the next slide. So through an integrated care model, the local clinic adopted this approach, and the staff received trainings on HIV care. And so he was able to get services at that local clinic with that training, and get all of his care, not just HIV, but more integrated care at that facility. Through medication delivery services, this is something I know Bengal Pharmacy has been doing for quite some time, but helping get medications to people, stores, in a way that reduces the burden of transportation, and doesn't disrupt treatment. Having a dedicated case manager assigned is also something that could help provide consistency and navigate the health system, the appointments, care coordination, etc. So then let's think about going out one more level to the public policy level. What are some things that could help support John in his HIV infection and increase medication adherence? One would be to reduce stigma that still occurs related to HIV. So the local health department is involved in this case in launching a campaign that increases HIV awareness in rural areas, makes it less stigmatized, and creates forums to discuss in schools, public forums, partnerships, etc., to talk with community leaders. Supporting policy changes that increase access to healthcare, not just for medication for HIV, but all levels of healthcare. And then community health workers is an area near and dear to me, but is an area that can be built out in so much of a bigger way in Idaho. But we're making some progress, and having, in this case, community health workers to provide HIV education and support residents in rural areas, act as a liaison between John and the healthcare system. So as an outcome, by having multi-level interventions, not just antiretroviral medication, John was able to achieve sustained adherence. Viral loads remained undetectable. He maintained good health. And this approach left him empowered individually, feeling supported, feeling like his clinic cared about him holistically and as an individual, and not just about the issue of medication adherence. And he was able to see some structural changes in his community that created an environment that helped making something like long-term adherence to an HIV medication much more feasible for John. So I know oversimplified, I know missing some key components, even best practices, but just use this case to show the multiple levels of interventions that, as clinicians, we need to be thinking about. As public health practitioners, we need to be thinking about the multiple levels that we need to be involved with to ultimately drive down the HIV and STI epidemics in our state.
Okay, talk a little bit about combination HIV prevention. According to the United Nations Joint Program on HIV and AIDS, combination HIV prevention is defined as those right-based, evidence-based, and community-based programs that promote a combination of the biomedical and behavioral and structural interventions designed to meet the HIV prevention needs of specific people and communities. And so the goal is to reduce the number of new infections through activities with greater sustained impact. Well-designed combination prevention programs should be tailored to national and local needs and based on epidemiological information. And the programs should concentrate resources on combining activities where they are most needed. And as Ryan has mentioned, structural interventions creates that enabling environment for the synergistic prevention or preventive actions of the biomedical and behavioral interventions. And also to keep in mind that affected communities should be fully involved in these combination prevention programs and mobilizing community members, private sector, government resources to achieve the necessary participation, coverage, sustainability, and impact. So the World Health Organization recommends a comprehensive package of health services for HIV prevention, which includes such considerations as mental health, human rights and health, sexual and reproductive health, making sure that treatment is available to everyone as a form of prevention, and of course, management of co-infections such as viral hepatitis and human papilloma virus infection and other sexually transmitted infections.
Thank you, Nnamdi. So for the last few minutes, we'll talk about challenges and barriers and future directions in HIV and STI prevention. And then I wanted to leave a few minutes at the end for questions or comments, and then let you go about 5 minutes early so you have time to walk to your next meeting. So I am very aware that I speak quickly, and I might tend to speak more quickly for this presentation just so that we can finish up our last few slides here. So if I'm talking too quickly, please let me know and slow me down. Some common challenges and barriers to preventing and caring for people with HIV are the social and self-stigmas that society experiences. And these are very real. And it's not just perceived, but actual discrimination as well. As Ryan discussed, there are geographical and financial barriers. There are barriers related to infrastructure and workforce. And then we are not acultural beings. We all have our cultures and our upbringings and our understandings of the world and how it works. And so with that comes some cultural taboos or religious opposition, different belief systems that people have about prevention or care. So it's really important for us as healthcare practitioners and public health practitioners to be very aware of our potential cultural biases. And I know that it's super easy to say, oh yeah, everyone has biases, I have them as well, but to really be mindful of those and take note of those in your interactions with your patients or community members to see how you can be a force for good when addressing these challenges and barriers, especially for people with HIV and STIs in this context. The other barriers that we have that are very real in our state are lack of awareness and education. Our state does not require comprehensive sex education, and I know you've heard me talk about this before, but comprehensive sex education, starting in middle school and high school, and then continuing on through young adulthood is so important. I've talked with many individuals who are not where I would like to see them be on that continuum of awareness and education. And it even can go down as far as talking to our family members, if they are toddlers or elementary school people, about their body parts, and just calling our anatomical terms by name and using those. And that just helps create a level of comfort in having these conversations by the time we are adults and practicing in our fields. And when we're comfortable having those conversations, then people are more likely to feel comfortable to have them with us, because we seem like safe people to be conversing with. There are also social inequities, gender inequality, income inequality, and LGBTQ plus discrimination, and then legal barriers. So as Ryan mentioned, we've had some legal barriers to HIV prevention and care. And now in Idaho, it is not legal to provide transgender care for minors using public funds. Next slide, Namdi. So here, the next two slides are a table of solutions, evidence-based solutions, and the strength of the evidence associated with those solutions to the challenges that we know about. And I wanted to point out that all of the strong ones are public awareness campaigns, anti-discrimination policies, and then increasing access and community engagement as far as cultural and religious beliefs. For example, evidence is moderate to strong to work with religious leaders to help them feel more comfortable about having these conversations and promote screening and promote treatment and prevention options. And then helping to speak into our medical and public health programs. If we get community members involved who can help us to create culturally sensitive programs, then that can help end the issue as well. Next slide, please. Again, with comprehensive sex education at age-appropriate levels, there are digital campaigns addressing those social inequities, creating and making available and promoting gender-sensitive health programs and LGBTQ inclusivity, and then reducing legal barriers, reducing the legal barriers associated with behaviors, decriminalizing behaviors that are typically associated with HIV transmission, and then offering harm reduction strategies at the population level. Next slide, please. So for future directions, we are looking at long-acting injectable PrEP or other long-acting HIV prevention tools like injections, antibody infusions, other injectables, intravaginal rings. As Dave mentioned, HIV vaccines are underway. So the US clinical trials begin for the twice-yearly HIV prevention injection as well. We're hopeful that we will be able to have an HIV vaccine in the future. Then broadly neutralizing antibodies, multi-purpose prevention technologies, CRISPR technology, digital health tools, HIV self-testing kits can be very important, and destigmatizing microbicides like for vaginal microbicides can be effective. And then AI for targeted prevention, not just targeting the highest at-risk groups, which we know AI is really good at sort of providing those geospatial maps, but it can also be helpful with evaluating our interventions and our programming. And then peer-led digital outreach and social media campaigns. As much as we can work within and alongside communities to get community input, we know that those interventions and campaigns will be stronger and more acceptable to those communities and be more sustainable. Next slide, please. So all of these future directions would not be necessary if we worked towards an inclusive and just society, if we all recognized health as a basic human right, if we worked within a supportive legal framework and had a robust educational system. And they can be effective and will be most effective when they're broadly available, when the health systems can distribute these options equitably, and that they are accessible and made available globally. Next slide, please. So we want to make sure that we are having these conversations not only with our clinicians and with people at risk, but with the broader community, and then making sure that our instructors at ISU feel competent and confident in their ability to cover these topics in the training of our future practitioners. So we're happy to answer a few questions. Thanks so much for coming today. We're really glad to see you all.
This is Melody. I want to say thank you very much. That was a nice overview of the issue and how things are being handled or could be handled. Appreciate it.
Thanks, Melody. And thank you, Gina, for your comment.
Yeah, this is Chris Owens. I don't know if you can hear me. But I wanted to thank you too for a great presentation. I think one of the barriers probably is also cost. Can you talk about the expense of some of these? Doxycycline is not very expensive, but the others probably do have some economic concerns. I don't know, Dave, do you have any like just general figures on that?
So now with oral PrEP, the combination of what is a brand medication called Truvada, it's now available generically and it has been for several years, and can be purchased for even on drug discount cards for like $25 a month. It's also covered by all insurances, covered by Medicaid as well. Not all insurances. I should also say that there are some private insurances that, because the medication is associated with sexual activity, such as men who have sex with men, they may choose not to cover it. So again, back to the barriers that Kristen highlighted, and to some of the things that Ryan highlighted. You know, they might be able to afford the $25 a month for the medication, but going in for the office visit every 3 to 6 months, or paying for the labs to screen for HIV or STIs, that's where it can also get expensive. So until we have, again, I think a broader, improved access and supportive financial options, there are still going to be barriers. And the long-acting injectables, Chris, are quite expensive. We're talking, several $1,000s per injection. I don't know what the lenacapavir will be priced at. It is available right now for the treatment of HIV, so we have an understanding of what it might be, and it's really expensive.
Yeah, I wondered about that, especially the long-acting one. Yeah, and that's actually a really good point about the screening in the lab and office kind of fees that are in there too. Yep. Okay. Thank you.
You bet. Kristen, did you want to let everybody go 5 minutes early?
I'm fine with that. It looked like Andrea had a question. Is there a timeline for the vaccine that's being developed?
For the HIV vaccine, there have been, as Kristen highlighted, lots and lots and lots of clinical trials with HIV vaccines, typically in areas around the world with higher prevalence, and none of them have really shown significant promise. They are looking at other, and I'll let Kristen comment if she's familiar with the other trials, but there are, again, approaches that we're looking at, for like functional cures, ways to modify the immune system to have it keep HIV at bay without all the daily medications. So there are other approaches, but historically the vaccines have just been so challenging.
Yeah, it's my understanding that the vaccine in the traditional sense has a long way to go, but they are trying to create like mRNA and the broadly neutralizing antibody vaccines. So the vaccine, as we've sort of traditionally thought about it and hoped, is a long way out, but some of these newer technologies are allowing for, like Dave said, that treatment, and then using the gene technology with CRISPR to create some different targeted approaches.
Yeah, and they're also referring to them almost as like therapeutic vaccines, as opposed to, as you were saying, the vaccine in the traditional sense that I think we sometimes can get hung up on. So yeah, different approaches. But for those interested in regards to HIV, there have been several approaches for patients that also have had, I believe it is certain types of lymphoma, where they have had bone marrow transplants with individuals that lack a specific gene. It's called the Delta 32 mutation, which after the transplant, off of medication, at least a half a dozen people, well documented in the literature, have had no detectable virus. So there is some approaches that are being explored there.
Thanks, Dave. I'm happy to stick around for a few more minutes for questions, but I want to be mindful of the time. And thank you so much for joining us today for the KDHS Grand Rounds.
Thanks, everyone. I'm going to step out.
Thanks. Bye.
Thanks for coming, Rose.